Post-stem cell transplant maintenance is one of the areas that still has so much unmet need. In order to prevent relapse after stem cell transplantation, we have adopted multiple modalities, such as increasing the conditioning regimen intensity, as well as using other forms of donor cell modalities. However, maintenance therapy has emerged as one way to prevent relapse. It's not yet, maintenance therapy after stem cell transplantation is not yet well defined or is not yet well defined. However, in the recent years, there have been multiple clinical trials that have tried to define the role of maintenance therapy. It is reasonable to use maintenance therapy when the risk of relapse after stem cell transplantation is higher than 30% at the 1-year mark. Recently, there have been multiple clinical trials that have addressed many drugs in the maintenance therapy area. For instance, there have the most recent one is called the SORMAIN trial that assessed the use of Sorafenib for the FLT3 positive AML as a maintenance therapy after stem cell transplantation. It has shown improved overall survival, and it is now the standard of care for this patient population. However, there has been another clinical trial, which is much smaller, called the RADIUS trial, which used Midostaurin in order to prevent relapse in the maintenance therapy. Unfortunately, this trial was very small and it did not show benefit. We are now waiting for the BMT trial 1506 that is evaluating Gilteritinib in the maintenance therapy. I'm very excited about this one because it's being used in the current era where Midostaurin is incorporated in the induction and the consolidation therapy for acute myeloid leukemia, as opposed to the RADIUS and the SORMAIN trials. Other drug that could be used for maintenance therapy is Azacitidine, for instance, or hypomethylating agents. A recent clinical trial published in Blood Advances by Oran and colleagues looked at azacitidine maintenance for patients with AML and MDS after stem cell transplantation. It was a randomized clinical trial. However, it did not show any improvement in overall survival with the addition of a hypomethylating agent, in this case, azacitidine, for the maintenance therapy. In this study, there has been some concerns that patients who underwent stem cell transplantation, especially in the AML patients, at least 50% of them had active disease at the time of transplantation. I'm not sure that this trial reflects the current practice where we transplant patients who have much better disease control. So I think that there's definitely still a role of maintenance therapy in AML after stem cell transplantation. Particularly, I think about it in patients who have received reduced intensity conditioning regimen, or patients who are not eligible to get a myeloablative regimen, and patients whose disease is MRD positive prior to the stem cell transplantation. I think those patients categories would benefit from maintenance therapy, particularly if they have high-risk disease, such as high-risk cytogenetics or high-risk mutation panel.